That all sounds good. I've got 1 minute after 6. So if you want, I will do my best to kick things off. I want to let everybody know how glad I am to see you all have tuned into this. I know that we've, in month 10 now of all this, we've probably reached the breaking point where the last thing we want is one more Zoom call and one more discussion about COVID and everything that's associated with it. But the idea of assembling this group of fantastic people that we have was to kind of give everyone a different view of what the issues are, what the lay of the land is, where we're headed, how soon we hope to be able to get there, and what all those things mean. Let me recognize that we've got a wide variety of people on the call, most of which are our own district Rotarians, but we do have a fellow Flamingo in Governor Mark Skolnick and Irma are joining us from Florida. Our governor nominees on the call. We've got several assistant governors on the call. We've got members of the leadership team on the call, and we're well represented across the state with different clubs. I see Newburgh, I see Huntington, I see Fayetteville, I see Kingwood, I see Morgantown, Charleston, Parkersburg, Beckley, so that you folks are not speaking to any one particular person. We've also got a past governor on the call. Here comes our public image chair. So welcome to everyone. Thanks for taking time out of your schedule, and thanks to our presenters for taking time out of theirs, which we can all only imagine how busy they are right now. Just as a little bit of housekeeping, if you would, if you're not speaking, I would ask you to put yourself on mute. That's just out of courtesy for the folks that are. If you don't mute yourself and you get a little too boisterous, I will mute you. That is one of the benefits of being the administrator on the call. I will try to keep things moving as smoothly as possible. You might want to use the speaker view to maximize your involvement in the call. We will do our best to maintain a certain schedule. This was broadcast as being only an hour long. If people want to talk longer and congregate further and enjoy a little fellowship, you're more than welcome to stay, but I'll try my best to keep everybody on time. If you've got a question and you don't want to interrupt anyone, please feel free to type it into the chat in all caps. I'll do my best to monitor the chat and ask the questions of each of the speakers as they conclude. Although Dr. Marsh Clay, as he prefers to be known, has already invited anyone to interrupt him along the way with any questions you may have as he speaks. Any questions that don't get asked because of time constraints, I will do my best to forward them to the different speakers and ask as time permits in the future that they maybe provide us with some sort of response to that. So without further ado, let me introduce our first speaker. Most, if not all of you, will know who this gentleman is. Locally and vocationally, he's the Vice President and Executive Dean of WVU Health Sciences. Nationally, he's a leader in personalized and pulmonary and critical care medicine. He has concentrated his efforts in determining how to help individuals stay healthy and how to create ecosystems to make this easy. He's a two-time graduate of West Virginia University, earning his undergraduate biology in 1981, a medical degree in 1985. Then, for whatever reason, he decided to go west and became a Buckeye at Ohio State for the next 30 years. We won't hold that against him, at least not publicly. He did serve a residency in internal medicine there, a research fellowship in pulmonary and critical care, chief residency in internal medicine, fellowship in pulmonary and critical care medicine, extension research fellowship. The accolades go on and on and on. If he's like me, he doesn't want to hear more about himself than he has to, but probably for purposes of this call and most recently with regard to his vocational background, he was named by our West Virginia Governor, Jim Justice, as the COVID-19 czar. I can only imagine what all is involved in earning such a title, but in such role, he at least coordinates the state's response to the challenges of the virus, collaborates with all different levels of government agencies, health officials, and researchers. In English, folks, in terms of the coronavirus in West Virginia and beyond, he is the man. So without further ado, please allow me to introduce and give a warm Rotarian welcome to our first speaker, Dr. Clay Marsh. Clay, the screen is yours. Feel free to educate us.
Thank you, Sean. So thank you, everybody. And like I said, it's really quite a pleasure and a privilege to be here with you. You know, it's really interesting to be part of a generational event And because of that, we've had to adapt rapidly to information and evidence as it came to us. Let me give you guys a very quick sort of Monarch Notes, Cliff Note version of what COVID-19 is, what we're trying to do about it, and then move very rapidly to where we are today, what's going to happen with the vaccine, what are the vaccines, and then talk a little bit about the future. So COVID-19 is caused by a virus, and the virus is called a coronavirus. And the reason why it's called a coronavirus is, remember when we were kids and we drew a sun, and there was a center circle, and then there's a bunch of lines that went out from the circle? Well, the circle is like the body of COVID-19, of the coronavirus. And it's like a big fat dropule. It's like a thing of butter, a pat of butter. And the lines that go out from it are the protein that sticks from the middle of the virus that forms the corona, like the rays of the sun. And that's called the spike protein. And that's where all the action is. The spike protein, that line that sticks out from the middle, is where the virus binds to receptors in our bodies. And those receptors are basically everywhere. And that's the reason why this virus is so problematic once it infects people, because these receptors are on our blood vessels, in our heart, in our brain, in our kidneys. And so the virus can bind anywhere these receptors are, the lungs. And what we found is that this virus will bind, and in about 24 hours inside your cells, there'll be about 10,000 copies of this virus. And then about 3 or 4 days in your blood, in a teaspoon of blood, there'll be about 100 million copies of this virus. So this virus amplifies really rapidly, and that's one of the problems. And initially the thought was that this is a virus that affects the lungs, because a lot of people in China who died from the virus were older people who smoked, men, and they were dying of lung disease. And so we thought this was a lung disease, but now we really understand this is a total body disease. The blood vessels are probably the main target of COVID-19, and the blood vessels goes everywhere, because at the end of the day, because it goes everywhere, we now know the virus can bind and indirectly infect the heart. In fact, there was a study from Germany that looked at 100 people that were about 71 days out from their COVID infection. 2/3 were outpatients, so pretty healthy. 1/3 was inpatients, average age about 50 years old. And using really sensitive heart tests, magnetic resonance imaging, MRI of the heart, they found that about 80% of those people had cardiac problems related to COVID, 71 days out. And about 60 of those people have what's called myocarditis, inflammation of the heart. And that's the reason why the Big Ten, or the Big 12, Big Ten, and the Pac-12 canceled their football season, because we know now, and student athletes as well, that people that have gotten COVID, if you look really closely, about 30 to 50% of those athletes will have some very subtle abnormalities on heart tests, not the severe kind of problems they saw in Germany, but this virus does affect the heart. There's also people who have brain issues, because the virus can cause blood clotting. So strokes and heart attacks are more common with the virus, but also many people feel a little fuzzy, hazy, not right for a bit afterwards. There's a study by the CDC that looked at people who had outpatient COVID-19 who were 18 to 35. And what they found was that 33% of those people at 3 weeks didn't feel right, and 20% of those people couldn't go back to work. And so there's been a recognition of people that don't die of COVID-19, but have ongoing problems. And these people are called long haulers. And the long haulers are people that are affected by this virus. So the virus is a very capable virus. The other challenge with the virus, and the reason why it spread so much to much of our world, is the virus can spread through droplets and through aerosols. Now, at the very beginning of the virus, remember everybody was really paranoid about getting a package in the mail, or going to the store, or touching a counter, because we thought that you picked up the virus and you introduced it to yourself. And it turns out that's really not the way this virus spreads. The virus spreads because of other people talking, singing, breathing, yelling. And the people that can spread the virus the best are the people that generate more aerosols and generate more droplets. That is probably the reason why young children don't transmit this virus nearly like adults, because their airways are small. They can't generate these droplets and aerosols. But what's important is, if in environments where people take their masks off or where they're together and close to each other, then the spread of the virus can happen. And for instance, in South Korea, one person led to the infection of about 3,000 other people because he went to a few mega churches. We know in Seattle, Washington, in one choir practice, one person who was infected, who could spread readily, infected 56 of 62 people in a 2-hour choir practice. So ultimately, so that's the reason why we tell everybody wear a mask and stay physically distanced, because a mask reduces the amount of droplets that you can generate and how long those droplets stay airborne and how far they're dispersed. That's also the reason why indoor environments are so much more dangerous than outdoor environments, because in outdoor environments, you disseminate those droplets and aerosols into the environment, and they spread and become much less concentrated very quickly. Indoors, they don't. And when you have an indoor environment with a bunch of people talking, those droplets build and build and build and build. And there's just an article that came out in the LA Times where in South Korea, they found that one woman who was infected with COVID-19 infected a person who was 20 feet away from her in an indoor talk in a restaurant, who was only there for 5 minutes, and that person got infected. So ultimately, we know that if you have an exposure of somebody with COVID-19, then you have a higher risk of getting COVID-19. But here's what's really interesting. So when you look at household spread, what would you guys think? How likely would it be if you were married to somebody, or you have a kid all living at home together, and one person has COVID? How likely do you think the other people in the house will get COVID? How frequently would you say? Would you guess?
I want to say very frequently. I'm not sure if that's a percentage necessarily, but
it's 9 to 17%. So it's actually pretty unusual. And 70% of people with COVID don't spread to anybody else. But there's a group of people, a small group of people, and they've been called super spreaders, that is about 5 to 10% of all people infected with COVID that spread to about 80% of everybody else. And these are people that can aerosolize and create the droplets that are really filled with COVID, but also are small enough that they stay airborne for a long time. And we know that singing is a big risk factor. Yelling is a big risk factor, but even just quiet breathing generates these droplets. And again, that's why we tell people to wear masks and stay physically distanced. And now we know that even just cloth mask, and if you have a mask and you want to know if it's good, hold it up to the light or the sun. If you can see the light or the sun shining through it, probably not a great mask. You want 3 layers, but if it kind of blocks that light, you're probably fine. But now we know that the mask also reduces the quantity, the concentration of COVID-19 that you get, which protects you as well. So masks are good in protecting others from you, but also protecting you from others. And in fact, if 80% of people in an environment are wearing good masks and wearing it over their nose, got to cover your nose, then we know that you get the same impact on the spread as a vaccine will get. And if 90% are wearing a mask, you actually have better effect than a vaccine does. Now, let me just tell you kind of a fun mathematical fact about COVID, which I think is really interesting. So there's something called the reproductive, instantaneous reproductive index, which is that RT or R0, R0. And that is how the virus spreads. So if you look at influenza, the flu, then basically if I have influenza, I'm on average going to spread it to 1.2 to 1.5 other people. COVID-19 has a reproductive index of 2 to 2.5. So meaning if I get infected, I'm likely to infect 2 more people to 2.5 more people. Well, let's just say it's 2 people. I just want you to understand. You guys know about compounding. You know, if you're young and you invest money, it makes a lot of money because it has a chance to compound. Well, the same issue happens with COVID. So COVID has a doubling time where it basically grows and doubles about 6 days, okay? And so if you go to 10 doubling times, which is about 60 days, and you have 1 person with COVID, then basically 60 days later, you will have about 1,250 people infected, okay? And that doesn't sound like a lot. That's, you know, so let's say you go 1 more, you know, 10 doubling times, which is 2 more months, which is 4 months from the beginning, and you haven't broken that chain. That 1 person with COVID now will have infected 1 million people, okay? And let's say that you don't break that chain in 2 more months, 6 months from the very beginning, that 1 person will have infected 1 billion people. That's with a B. So you can see this compounding effect, and that's what happened in New York City. That's what we call surging. When enough people get COVID that they're spreading it to enough other people and you can't stop that chain, then you get this exponential compounding, this doubling that happens. And that's if the index is 2, COVID's really 2.5. So it means it's even greater than I just told you, but the math is easier if you use 2. So you can see that COVID is really a problem because it spreads silently and it spreads through droplets that you can breathe in and not even know that you're with somebody who has it. And we think that at least 50% of the time, maybe as much as 75% of the time, the people that spread it to others, those super spreaders, spread it when they're asymptomatic or pre-symptomatic. So 2.5 days before to the day of symptoms with COVID is a time that people have a lot of virus. And so that's the reason too, why we do a lot of testing, because we want to identify those people who don't even themselves know they have COVID, who might be spreading to a lot of other people. And that's what happened with that 1 person in South Korea that spread it to 3,000 other people. And there's been this kind of finding too. Small number of people spread to a lot of other people. A lot of people, 70% of people with COVID don't spread to anybody else. So does that make sense? Is there any questions on that part? So just explaining why masks and physical distancing and avoiding indoor environments. Japan says avoid the 3 C's, crowds, indoor closed spaces, and close contact with people that you don't live with. And a meaningful contact is 15 minutes of time, 6 feet or less from somebody with COVID over a 24-hour period of time. That's cumulative 15 minutes. So it could mean 2 minutes here, 2 minutes again, 2 minutes again, total of 15 minutes. So it's not a lot of contact with people over, you know, a longer period of time. But that's the reason why we tell people to be really careful about being around other people you don't know. Be real careful about being in environments where people take off their masks, like in restaurants and bars and gyms and coffee shops and casinos. All those places, to me, should be off limits to people until this is done. Okay, so does that make sense? The kind of bit of that's a little cliff note background of what COVID is and why we're doing certain things. So today in the US, we are seeing more cases. So back in the summer, when we were seeing a lot of activity from COVID, remember Texas and Florida and Arizona were having all this problem. Well, 60,000 cases in a day was a lot of cases. Today in the US, we are averaging almost 200,000 cases a day. So just to give you a reference. So the first 1 million cases of COVID took 100 days to reach in our country. The second 1 million cases took 44 days to reach in our country. The most current 1 million cases took 5 days to reach in our country. And yesterday was the very first day that we passed 3,000 deaths in a day. So yesterday was the first day that we passed in a single day of COVID in the US, more people died than died in all of 9/11. So that's a reference point. And so if you look at the number of people dying, we're going to be close to 300,000 Americans dying from COVID here in the near future. And we see the spread of COVID. So more people are diagnosed with COVID on a daily basis than ever before. More people are dying in a daily rate than ever before. More people are in hospitals in the US than ever before. More people are in ICU beds in the US. And in fact, in San Francisco, they are projecting they have 11 days of ICU bed capacity. And I can't remember which state it's in, but one state, they've already started to turn parking garages into hospitals. And so when you surge, when you get that exponential growth, and particularly as people get sick, then people come to the hospitals. And the biggest risk to our, mortality rate is really two different groups. One are nursing home patients. So 47% of people that have died in West Virginia were nursing home residents. And that's a big part of the target for the vaccines that the CDC group has recommended, and we are going to do in West Virginia as well. The other side is when hospitals fill up and you can't fit people into ICUs and the hospital staff gets sick because they live in the same communities everybody else does, then the mortality rate goes up. And not only up for COVID, but it goes up for heart disease, heart attacks, strokes, infections, cancers, because you can't take care of the other problems. And that's one reason why we really are trying to protect our hospital capacity, particularly our intensive care unit, our really sophisticated sick hospital care capacity. And currently in West Virginia, we have more COVID patients in the hospital and hospital beds and in ICU beds than we've ever had before as well. So I think that as we go forward, COVID is growing, and the more it grows, the more ultimately hospitalized people you have, ICU people you have, people that die of COVID. And in West Virginia, we look at two measures to give us an idea about how the COVID is spreading. One is a measure called an incidence rate, and the Harvard Global Health Institute has really focused its map on that measure. And it basically measures how many new cases a day do you have on average for a 7-day rolling average, and then you correct that for 100,000 population so you can compare every county across the United States with each other. And the second one is a percent positive rate, which measures how many people test positive with COVID-19, and we use the genetic test, the PCR test, and that's divided by all the tests that you're doing. And in West Virginia right now, when we look at the highest rate of spread and the next highest level of spread, then about 39 of our 55 counties are either in the orange or the red. And if you look purely just by the incidence rate or the infection rate, the Harvard rate, and we have modified it a little bit because we're not counting all people that are like in correctional facilities or nursing homes. We're just counting community cases because we want to look at community spread. Then all but one county is red right now. And at least about 5 or 6 counties are over 4 times the upper limits of that measure in our threshold. So we know in West Virginia, COVID is spreading rapidly. We know across the country, COVID is spreading rapidly, and it's spreading very deep into a lot of communities. And rural communities were really protected to begin with because, like everywhere else, the places that are most connected, the business centers, the big airport hubs, that's where all people come from international travel. COVID was first described in Wuhan, China. So coming from China through Europe and across to San Francisco, California was our earliest cases, and Washington State, and that's because that's where a lot of Asia comes back to go to the United States. But now we have found in New York City at one point led to over 75% of the cases in the eastern part of the country came through New York City, but now it's everywhere. Rural environments, urban environments, it is widespread. And so that's the reason why we try to test aggressively, because we want to find who's infected and separate them. We want to contact trace aggressively to find who were their contacts and separate them as well. So you're breaking that chain of spread. But when things get high enough in the number of people that are infected, and there's enough on a daily basis, you start really losing the ability to control things that way. And that's the reason why certain states now are doing other kinds of measures, mitigation measures, like shutting down bars or restaurants or or, having people work at home. So it turns out that, if you can identify places where you have more likely spread and you can kind of shut those down, or at least make those, change some of the hours or whatever, sometimes that can quiet things down a little bit. But eventually, the determination of whether you can control COVID or not is really based more on each one of our personal behaviors as it is on anything else. And that and the vaccine. So the real way to control COVID-19 is to protect yourself, because by protecting yourself, you protect others. And you protect yourself by wearing a mask when you're out or around other people, staying physically distanced. If you're around other people, eye covering is also probably a good idea. Hand washing, definitely a good idea. But avoiding indoor crowds, indoor environments, and contact with people you don't know. And the problem that we have right now in the US and in West Virginia is the Thanksgiving holiday. So using mobile phone data, mobility data, the Thanksgiving holiday was the most mobile single time since the beginning of the COVID-19 pandemic. So more people traveled, more people moved than any other time. And TSA reported more travelers on planes than any other time since the beginning of the pandemic. And now we're coming into the December holidays. And it takes about 2 to 4 weeks after you've contacted and people are spreading COVID before you see the biggest impact on hospitalizations and deaths. And that's the reason why Tony Fauci is basically saying we haven't seen the peak of the Thanksgiving effect yet, because it's about 2 to 4 weeks after. And we're now in that sort of 2 to 3 weeks. So we anticipate we'll see more problem from that. And then with the Christmas, Hanukkah, Kwanzaa, with those holidays coming up, and the New Year's, we know there's going to be another sort of, perhaps stair step of surge coming from those holidays, which should go well into the January time. And the colder it is and the more people are together, the more likely you'll get spread too. And that's the reason why a lot of people are really, really concerned that the next 2 to 3 months until the weather picks up and people get back outside again are going to be really problematic. Now, at the same time that's happening, and that may be kind of the bad news, the good news is that the FDA advisory group just recommended tonight, just right before we started tonight, for the FDA, the Food and Drug Administration, to approve an emergency use authorization for the Pfizer vaccine. So the first part of that approval is thumbs up. And we know that England, UK, and Canada both approved the Pfizer vaccine to be used. And the second stage for us is a CDC advisory committee, the Centers for Disease Control, and they meet, I think, on Sunday. So if they recommend too, then we'll get the vaccine approved next week. Now, let me just tell you quickly a little sort of Cliff Notes version again. So the fastest vaccine ever made and ever distributed is the Mumps Vaccine, and that took 4 years. So this, vaccine set that we're seeing around COVID is remarkably fast. I mean, like unbelievably fast. And the technology, the new approach used for the Pfizer and the Moderna vaccine, I think are game changers. I think it's going to change the way vaccines are done for everything. And let me explain really briefly what these vaccines are. These vaccines are called messenger RNA vaccines, and that doesn't mean anything to people. But what it means is that you can create a synthetic genetic code that basically tells the body, because this will get into our cells, it tells our cells to make this component of the virus. That spike protein, the corona, the lines that stick out from the middle, that's where the virus binds to the body cells. That's where the virus infects us. And what you tell the body to do is you make an immune response just against that part of the virus. That is the action part of the virus. And the way that these vaccines work, they're packaged in a fat dropule called a liposome. And it gets into the cell. And once it gets into the cell starts to make, it's the blueprint for the cells to make that part of the virus, but it's not really a virus or anything. It's synthetically made. So it's broken down quickly in our cells and it cannot infect you because it's not a virus. It is just a little piece of the virus that's broken down. So it's really safe that way. And Pfizer and Moderna, which are really kind of the same vaccine, the difference is that the way that Pfizer packaged their vaccine, the fat dropule, is a little bit more fragile than the Moderna's fat dropule. So you have to store the Pfizer vaccine at an ultra cold temperature because it starts to break down if you don't. And the Moderna vaccine is a little bit more stable, but both are really effective. They're both 95% effective in the clinical trials in preventing people who got those vaccines from getting COVID. The Moderna vaccine protected older people. Pfizer is testing that now. The Pfizer and Moderna vaccine, one person in the Pfizer group, nobody in the Moderna group had any severe disease. So even if you're one of those 4 or 5% of people that got the virus, even though you got the vaccine, almost nobody got severe disease. Nobody died in either one of the vaccine groups. And they had to compare it to an injection of water basically. And several people died in that group because you had to compare to see how they were. So those two vaccines are going to be the first two vaccines out. And the Pfizer vaccine will get approved, we believe, early next week. But it passed the very first step for that, and that was a huge step. And Moderna will be about a week behind it. And that's the vaccines that we will see circulated first in the US. When you have your chance to get the Pfizer vaccine or the Moderna vaccine, you roll up your sleeve and you say, thank you. Because these vaccines are really effective and they're really safe. In the FDA sort of brief, 4 people out of about 74,000 that were tested. Not everybody got the vaccine, half got the vaccine, half didn't. Had a little droopy face called Bell's palsy that gets better, and that is not that different than the normal population. And in the UK, they had just injected 2 hospital workers, and 2 people got a kind of an allergic-y kind of response from it. And so if you are a person that has to carry around an epinephrine pin because you have a really life-threatening allergy, you need to talk to your doctor before you get the vaccine. But otherwise, these vaccines, other than being like the shingles vaccine, it hurts a little bit in the arm. You get 2 doses, 21 days apart for Pfizer, 28 days apart for Moderna, and you get pain in your arm. And then about 30% of people on the second dose of the Pfizer vaccine, I haven't seen the Moderna data yet, but kind of felt like they had the flu, felt crappy, and that's not you're infected, that is your immune system is really ramping up and it's releasing all those chemicals that fight infections that make us have fever and feel crappy, but then after about 24 hours, that was all gone. So these are really safe, really effective vaccines, and they can be made very quickly because these are synthetic genetic codes that are generated in a platform that is broken down by the cells. So really safe. The other 2 vaccines are the Astrazeneca vaccine and the Johnson & Johnson vaccine. These are made very differently, but those 2 are made differently, but the same. They're using a different kind of a virus to package that part of the genetic code that we want the body to make. And this is now used in rabies vaccines for animals. It's not quite as effective, at least in the first go round, as the Pfizer and Moderna vaccine, about 70, not 95%, about 70% effective. But these are going to be much less expensive vaccines. So for the developing world, these are going to be game changers because that's where these vaccines probably will have their greatest impact. But they also may be vaccines that are brought here to the US to be able to use. They are farther behind. So these won't be vaccines, really to be done until 2021. Now, one of the big issues is what groups should be prioritized to get the vaccine first. And the second thing is, will everybody take the vaccine? So the prioritization for the vaccine, there's an advisory group to the FDA, to the CDC, the Centers for Disease Control, and they recommended that you immunize hospital workers, particularly acute care hospitals, to protect ICU beds, COVID units, emergency rooms, so that you keep everything open, and the place where people die the most, which is nursing homes. So the first group that we will do as well will be acute care hospitals, particularly focused at ICU, emergency room, COVID units. We'll also prioritize physicians and healthcare workers that deal with airway procedures like anesthesiologists, nurse anesthetists, ENT surgeons, people around the airway, because that's a real high risk of getting infected. And we're also going to prioritize at this point likely pharmacists, because the way that we're going to distribute our vaccine is going to be through pharmacies and pharmacists, because they will understand how to take care of these really vital resource vaccines, particularly Pfizer, that's really kind of harder to work with because of the need for ultra cold storage. And then we're going to focus on nursing home residents and nursing home staff, since about half of our deaths come from there. And then as we start to look at other groups, although we haven't finalized yet, we'll focus on vital community groups, particularly first responders, EMT, fire, police. We'll focus on local health departments, some of our infrastructure support for the National Guard. Dentists will be into that group too because of the airway procedures they're around. And then we'll start to look at people that are more vulnerable. We'll look at people in the workforce who are over 60 or 65 years old, and people with other risk factors, you know, comorbid disease. And then we'll do what the UK did, which will start to look at groups of people who are older. The UK really structured their whole strategy around starting with 90-year-olds to get them immunized, then 80-year-olds, then 70, you know, and above, because those are groups, the older you are and the more co-medical problems you have, the more likely you'll get severely ill or die from COVID-19, and both to save lives and also to reduce that pressure on our hospital beds. That's something we'll do too. I'm not exactly sure how we'll do that, but we'll look at immunizing in that sort of next group. You know, the first group will mostly be the healthcare, acute healthcare sector and nursing homes, and then we'll get to more vulnerable people, working and non-working, and then we'll get to the rest of the population. And so we see sort of those three phases of how we're going to immunize. But, you know, we hope to have immunizations starting next week in West Virginia, if all goes well. And we're ready to do it. It'll be the most complicated mission that we've ever run. And I was just on the phone with our vaccine distribution group just before I got on tonight. So, and we report to the governor, and the governor is focused on maintaining vital capacity around healthcare assets and others, infrastructure, community, you know, first responder, government, and then also save lives. And that's what we're trying to follow in our distribution plan. So that's my little 2 cents on vaccines. Do you have any questions on that, or and a little bit on the distribution concepts?
Clay, I know you asked me to give you the 5-minute warning, but I looked around the screen. Everybody was so captivated. The last thing I was going to do was interrupt you and tell you that I was going to have to cut you off in 5 minutes.
All right. Well,
we do have a question that comes from our district alumni chair, a matter of fact, and that's Rick Falutis. Rick asks, how long does someone need to be infected before a COVID test will show positive?
that's a super good question, Rick, and good to see you. So there was an article, this is an important issue. So there was an article in the Annals of Internal Medicine that followed people who were infected and who got PCR tests. So there's really 3 ways to look for infection. There is the genetics of the virus, which is called a PCR test, which basically is like, you know, CSI Miami or whatever those crime shows where you take a little hair and you find out the killer from their DNA. Well, that's because you can amplify the amount of DNA using this method called PCR. And there's a funny story about that, but I won't go into it now. But PCR is the best test to do. It, though, is more expensive and takes longer to get back. But a PCR test at 5 days after you've been infected, only about 50% of the people will show positive on a PCR test. After about 7 days, about 70% of people will show positive. And then it kind of goes down again. So if you're right up front, if you just gotten exposed, then testing will be 0. At day 1, nobody's positive for any kind of test. So the testing you do is really dependent, and the timing is dependent on whether you're likely to show positive. The second way to test is a rapid test called an antigen test. That's like when we swab people's throats for a quick strep screen, or we do a nose swab for a quick influenza screen. That's using an antigen test, and that measures a protein on the surface of the virus. And it's really fast. And if it's positive, it's pretty good for being positive, but it's not as sensitive. It doesn't pick up as low a dose of the virus. So in low dose of virus, you can miss the virus. So it has that problem. If you're symptomatic, it's better than if you're not symptomatic. So if you get a positive antigen test, oftentimes we'll ask you to get a PCR test to confirm it. And then there's an antibody test, which measures your body's response against the virus. It's no longer measuring the virus, it's your body's response. But it could tell you, even if you don't have the virus, that maybe you had the virus at one point. And that's a test that may be done more with the immunization, because there is some thought from the CDC that they may recommend, if you've had the virus within a period of time, 6 weeks, 2 months, you shouldn't get the vaccine until you're longer after, because you would already have some immunity. It would be the presumption. But the clinical trials with Pfizer and Moderna did not exclude people that had been diagnosed with the virus. So now you would get the shot whether you had the virus or not. Didn't test pregnant women, but the thought is because pregnant women have a higher risk of getting COVID, that they would get immunized too. And didn't test immunocompromised people on, say, transplant medication or something like that. But all these with that mRNA vaccine, with the Pfizer, Moderna, because they're so safe the way they're made, the recommendations is all these groups should get vaccinated when they have an opportunity, even though we don't have data to say that these vaccines are completely effective in all those groups. Sean, you're muted, which some people wish I was muted all the time.
Rick, does that answer your question? That was a fine answer. You also broke the seal on the question committee. We've probably gotten another half dozen. I don't know that we've got time for all of them. Let me just, Nancy Barbie had asked, how effective are the COVID tests? I think you may have even answered that question.
PCR is very effective. Timing's right, but it takes a while to come back. The antigen test is less good, but much faster.
There's a question here about herd immunity.
70% of people need to be infected and responsive, at least with this virus, the projection for herd immunity. And immunizations give you herd immunity. Ironically, mask wearing can give you herd immunity if you do it enough. So ultimately, about 70% of people either need natural immunity because they've been infected, or need to be vaccinated for herd immunity. And herd immunity basically just means that if this is a chain of spread, that quickly you run into somebody, that it stops the chain from growing. It stops the compounding. That's the whole idea.
We got time for one more question, and one of our friends down in Huntington asks this one. What is the likelihood that we will find more adverse effects as people start getting the vaccine? It is my understanding that the people who went through the trials were volunteers. As such, how can we be confident that other people with risk factors won't be negatively affected as more people start getting the vaccine?
Yeah, I think that, that's obviously a $64,000 question. And in general, from the people I talk to who are really smart infectious disease people, usually it's about the first 2 weeks after you get vaccinated that are the really critical time. The FDA required 2 months after the last immunization for these 2 trials to be done for Pfizer and Moderna. And so the infectious disease people I talk to feel good about the side effect profile that way. The way these vaccines are made, they cannot possibly cause infection. That's good. And because they're broken down by the cells, that's good too, because they don't incorporate into your DNA. If you have DNA vaccines, sometimes they can incorporate, into your into your genetic code. These can't. So I feel very safe. I will tell you, I may well be asked to take a vaccine early just because of my role with the state to show confidence. I would not hesitate even a nanosecond to take it myself or have my family take it. The other key is that the reason why the UK and Canada has approved it before the US is everybody at the FDA and the CDC recognize what a high profile thing this is. And so they're trying to treat this, they're trying to make it happen fast, but they're being very vigorous and rigorous in their evaluation. And so they're trying to do this super quickly, but with a lot of intensity and a lot of focus on all of the data, because they know if a side effect does show up in the future and they missed it, that's going to be really amplified as far as the criticism of these agencies. So they're being extra careful in looking at it. But the way these things are made, I'm convinced. I at least for the Pfizer and the Moderna, I'm all in. The Astrazeneca and the Johnson & Johnson, I want to see a little bit more data. But I think that they look really safe too, from at least what I've seen.
Well, Clay Marsh, I can't thank you enough for that presentation. I mean, that word doesn't do it justice. I, for one, am a student of all of this. Not because I'm necessarily germaphobe. It's just because I don't have enough time to be sick.
Yeah,
so
that's right.
I try to find as many ways to stay well as I can. You are not a Rotarian, as I understand it, as of yet. If you ever want to become one, there's about 25 different clubs represented that would be more than happy to add you to their membership ranks. I will tell you this, that the Rotary International is associated with the Rotary Foundation, which I'm sure you know some about. And it is one of the greatest nonprofit causes in the world as far as anyone on this call is concerned. I can only imagine what your world has been like for the last 10 plus months. So I would be glad to let you know that it would be our honor if you would allow us as a district to make a donation to the Rotary Foundation in your name, not only for presenting tonight, but for everything that you have done and will continue to do to see us through this path of safety and health.
Oh, thank you. That is so nice. That's real. That touches my heart. Thank you so much. And I so appreciate what you guys are doing and who you represent and your driving purpose. It's really inspiring. And I'm sorry I talked much longer than I should have. My gosh. But I get going. That's the reason why I asked you to cut me off, because I kind of get lost in this. And I would say for me too, I'll stop after this. I am so privileged to be able to serve the state of West Virginia, but I have learned so much through this. And the biggest thing I've learned is the incredible goodness of the people that live in this state. You know, this is, it's so inspiring to see the hearts and the community and the love and the altruism and the service that you get all the time. Yeah, and there's some contrarians and there's some people that have a different narrative and stand on a different side of the street. But when push comes to shove, we all rally around each other. And that is what's so important to get through this. And it's going to be some rough sailing for a while. And I will tell you, what we've seen is going to be nothing, I don't think, to what we are going to see. And it's going to be really scary for people. But just, you know, just stay safe and don't travel and don't get around a lot of people. It's about 2 to 3 months. And if you can see it through that, then the lights, it's going to start getting a lot lighter and better. And the vaccine's part of it, but part of it's the weather and getting people out again. So take care of yourselves.
Well, I for one am glad to have reabsorbed you from the ranks of Ohio and welcome you back to your homeland. And
good news is I had a whole new wardrobe when I came back, because blue and gold is really good to wear here. In Ohio, right. That was like, you know, you were the anti, you know, whatever.
Right, exactly. Well, thank you again for everything that you've shared with us. We're going to move on to a similar topic, but maybe on the psychological side of how to, you know, face some of the things that you've shared with us that we're all more than familiar with, more than we would have ever cared.
I'm going to stay till 7 and I have to drop at 7, but thank you so much.
Please feel free to stay as long as you'd like. This next person that's going to share with us is someone that most of the people in this district already know. She is definitely a friend of our district. She is certainly my buddy. And if you've seen Facebook pictures, well, you can do that on your own. You don't have to look too deeply to know that this lady's very near and dear to us. She was first introduced to Rotary in 2002, and she was selected as a member of a group study exchange to Sweden. She has since then served in her own right as a district governor of what is now District 7305. She served as the Zones 28-29 North American Membership Project Leader. She's been the Zone 29 Rotary Coordinator. Again, her list of accolades go on and on and on. Most recently, she's been a trainer at International Assembly, and she and her husband were recently named as being the trainers of trainers for the next International Assembly that's coming up here in February. She's received so many awards: YWCA's Tribute to Women Community Service, Rotary's 5 Avenues of Service, the Rotary Foundation's Citation for Meritorious Service. They've hosted 9 exchange students at their home. They've traveled on many GSE teams. She has a definite passion. She has found herself as a worldwide speaker on the topic that she's going to share with us in the last 10 months. Every time I see her, she's being pumped into a different continent, it seems. She is a Paul Harris and Legacy Society member. She's also a major donor to our foundation. Without further ado, please let me pass the screen to my friend and yours, Dr. Mary B. Berg.
Thank you, Sean. And Clay, I want to thank you because I think you have effectively given us hope, but also raised everybody's anxiety levels. So you're all perfect patients for me right now. Raise your hand if you got a little anxious at any point during that presentation. Some of the things that we had to talk about. I don't get anxious very often, but I could tell my autonomic nervous system was firing the alarm off several times, and I thought, wow, I haven't felt anxiety in a long time. So thank you, Clay, because you've given me quite the lead in here to do my job now. I am going to skip a whole bunch of stuff because I want to just take you right to that, to what do you do during COVID-19, during any stressful time, it could be politics, anything, when you begin to really feel anxious and out of control, when your physiological system is really kicking on all of your anxiety centers. Let me back up a little bit and tell you a little bit about how anxiety works. So in our brains, we have these 2 little, Clay, you're going to kill me for the way I do this. This is just the way I think of it. These 2 little almond-shaped things in our brains called the amygdala, left side and the right hemispheres, both hemispheres. And they are really responsible for turning on our fire alarm, so to speak. So when we get anxious and worried, those amygdalas light up and they send a message to our hypothalamus, which then turns on all of our autonomic nervous system, and we start to sweat. We get butterflies in our stomach. We can't find our words. That's what we know as the psychological experience of worry or anxiety. And the interesting thing about anxiety and worry is that it requires time to ruminate. And anxiety really festers or thrives best when you are off into the future, when your what if thinking is turned on. You're what ifing. What if I get sick? What if I what if I was in a restaurant last week and there was somebody breathing on me? What if this goes on all through winter and into spring? What if I lose my job? Anxiety loves the what ifs. Now, anxiety also does pretty good in the past. That would be your would have, could have, should have thinking. Because again, you give it time to fester, to ruminate. But anxiety does not do well when you are in the here and the now and you're mindfully present. But that's pretty hard to do these days, isn't it? Especially after hearing all of that really wonderful information, factual information about COVID-19. It should have sent off your anxiety centers just at least a little bit. So what I'd like to do today in lieu of my normal talk is I'd like to bring you down. Take your anxiety away just for a few minutes. I'm going to teach you how to do 2 things that can help you to turn off the amygdalas, to turn off that relay system to the hypothalamus. Okay, so the first is with deep breathing exercises. And I know that may sound a little hokey, a little hippie-ish, but guess what? It really does work. So I want you all to do one with me, okay? So first what we're gonna do is I'm gonna train you how to do it. So you have to breathe in through your nose, and then we hold our breath for a few seconds, and then we breathe out through our lips. Now I want you to try to do the inhale and the exhale really slow. Focus on trying to pinch your nasal passages off somewhere in the back of your throat as you slowly inhale. And then hold your breath for about 5 seconds. And then when we exhale, we're gonna make this little shape with our mouth. And no, Sean, I'm not kissing you. But you pierce your lips, and that will control the breath like a little balloon, okay? And I want everyone to be sure you're seated, okay, because you can get a little lightheaded. And we're just gonna do one round. Normally I have my patients do about 3. So on my count of 3, get rid of all of your breath, and we'll do a slow inhale. All right, 1, 2, 3, get rid of it, and inhale. Holding. And exhale slowly. Good. Now check in with your body. Feel it. See if you feel anything different. See, I just caught it right there. I get this little biofeedback thing. It's in my jowls. That's the only way I know how to explain it. But I get a little sensation right here where something happens. It's just my feedback system that says, and I feel it right in here somehow. So let's do it one more time and see if you can catch where your body does it. Okay, inhaling slowly. Good inhales, holding. And exhale. Check in. Ooh, I just got a tingle. On the back of my head. That one went all the way back here for me. I don't know where you're feeling it, but just notice how you're a little calmer, a little happier. Anxiety has been reduced. Truly, truly effective. Now, another thing I like to use is this remarkable treatment called bilateral sound therapy. And bilateral sound is this interesting technique where you're going to listen to engineered music or nature sounds through earbuds or a headset. And you'll notice that you hear the sound in one ear and then the next, and then one ear and then the next. And you close your eyes, and as you do so, you'll notice that your eyes will begin to track the sound. You may even feel the shape of the sound waves differently with each tune or sound. And as your eyes and your ears are following that sound, a very particular type of brainwave begins to occur. And I was told that it crosses over actually the top of the 2 hemispheres, crossing the midline section. And it's that particular brainwave that turns off that anxiety amygdala hypothalamus relay system, shuts it down. It's as if the 2 cannot play at the same time in the same sandbox. And it is incredibly powerful. I'm using it with all of my patients. And you can get it for free on YouTube. You can get it in Spotify and iTunes. You can buy it on Amazon. It is wonderful with anger, irritability, depression, anxiety, sleep problems. And my favorite artist or resource is David Grand. He is a psychologist, and he's one of the sort of forefathers of this technique. He actually coined his bilateral sound, so it could be different. And you can get this for free, as I said, right on YouTube. This is my favorite album called Brain Spotting. And I have found this technique to be one of the most powerful things I have ever done with my patients for a multitude of issues. So after tonight, check it out, get your little earbuds in, If you're feeling still anxious, plug in 3 to 6 minutes, usually does it for most clients. If you have any problems with sleep, just plug in before you go to sleep. Within 6 to 12 minutes, you'll probably be out. A lot of times with my patients, I'll leave the room for a few minutes while they do this the first time, let them go for about 10 minutes. 9 out of 10 times I come back in and they're asleep, even after they had been having a panic attack. So this thing really does work. And I've just found David Grand's product to be one of the best. So check that out. And I'm going to stop there, Sean, because I think those are the 2 most key important factors I could give anybody right now to get through these next 3 months. You're going to have anxiety. That's okay. But now you have 2 new tools that you can use to almost immediately shut down that system. Because most of the fire alarms that are going off in our head are false alarms. If we just take care of ourselves and we stay safe, we're going to be okay. So, Sean, I'll turn it back over to you. Thank you so much.
Mary, thank you. Folks, we were at an event somewhere one time, Mary and I, for whatever reason, called her better than bourbon that day. And now I remember why. So if you all didn't find that experience to be better than bourbon, then you just weren't paying attention. In all seriousness, Mary is a fantastic Rotarian and even more fantastic person. And I thank her very much for agreeing to be part of this evening with us. I hope you enjoyed her abbreviated presentation. There will be plenty more opportunities to hear from Mary. She actually contributed to our pets last year. I suspect you'll probably see at our district conference as well in some capacity.
I'll put my email and the address or in the chat here. If anybody wants to have me speak at their club, I, of course, would be happy to do my vocational service for you anytime. Just email me.
Fantastic. Thank you again, Mary.
You're welcome.
Last but not least, another one of my buddies. This lady is a member of the Rotary Club of Maysville, North Carolina. She too is a past district governor in 2009, 2010. She has served her club. She has served her district. She continues to serve our Zone 33, most recently as our RRFC. She's been a club president 4 times. So for those of you who have not been club president yet, do not miss a meeting because she will nominate you to be the next club president. I promise you. She's been an international service chair. She's been youth services chair, secretary, foundation advocate, membership advocate. In her district, she's been the DRFC program chair. And again, as I said, she's currently our Zone 33 Rotary Regional Foundation chair. She's been a governor-elect trainer for the last 2 years. She has served as a Rotary International President's representative, both domestically and internationally. And she is famous for leading those National Immunization Day trips to India and has until this most recent year for the past 12. I suspect we'll see those resume one day soon. And I imagine Nancy will be in the forefront of the group that takes us there. Vocationally, she holds a BS degree in early childhood education, a master's in library science from East Carolina. She retired in 2007 from the state of North Carolina after 30 years of teaching. She continues to be an educational consultant in the area of technology for schools. She is also the recipient of the Service Above Self Award, Citation for Meritorious Service, Distinguished Service Award, International Service for a Polio-Free World. That is where her passion truly lies within our organization. She is also a Paul Harris Society charter member, benefactor, bequest society member, major donor, which all means if she ain't broke yet, she's going to be one day because she's given all of her money to the foundation. If you would, please give a warm Rotarian welcome to my friend and yours, Nancy Barbie. Nancy, the screen is yours.
Thank you so much, Sean. Such a pleasure to be here back in 7545. And I mean, Clay, I could listen to you forever. And Mary, I was anxious, but now I'm calm. And your breathing techniques and the music works. After you spoke at my club, I've started that practice and it truly does work. So thank you for that. I'm going to abbreviate mine too, Sean. I'm not going to show slides. I had a bunch of them, but I can come back and do a longer program because I just wanted to talk to you a little bit about polio. And as you all know, polio is our signature project, corporate project for the Rotary Foundation. And the eradication of polio is near and dear to my heart as it is to all of your hearts. And it has been a trying time during this COVID time. And I want to talk to you a little bit about the similarities of this pandemic and the epidemic of polio and what we're doing about it. So it's really interesting to note that
Nancy, you muted yourself somehow.
sure did, for heaven's sakes. Didn't mean to hit myself again. And there was a race to develop a vaccine just like today against the infectious disease. During the epidemic, polio affected and took lives of the young. And now it's really interesting to note that those very people are at high risk for developing COVID. And as today, thousands fled cities, movie theaters, bars, public gatherings stopped. There were non-existent. Parents were panicked and didn't know what to do. Schools closed, and there were a lot of deaths, especially in the 50s. We were in the midst of the biggest polio epidemic in history until today. It's amazing what Rotary has done with polio. And Rotary is a part of the Global Polio Eradication Initiative, or you'll hear me use GPEI, which is short for those particular words. And we use that vast infrastructure that's been developed to identify the polio virus and deliver vaccination campaigns. The polio eradication program is pitching in to protect the vulnerable from COVID-19 too, especially in polio endemic countries. Pakistan, Afghanistan are the two remaining endemic countries, as you well know. Thank goodness Nigeria has been declared polio free, and that means the whole African region is now polio free. But the vaccine campaigns stopped because of COVID, which was very detrimental to the cases the outbreaks that we've seen recently of polio. We are fighting the outbreaks, and we are supporting the governments as we respond to the COVID-19. Thank goodness the polio campaigns have begun again in Pakistan, and they began around July, I believe, in Afghanistan as well. But you know, those healthcare workers are also not just delivering polio vaccines, they're also teaching and training people about how to be safe during the COVID vaccine time, or COVID time, pandemic time. They're telling people the same thing that Clay just told us, and that we all have been told many, many times: wear a mask, stay social distance, stay away from people, don't do a lot of social gathering and in huge events. So they're telling the same thing. Those polio workers are in the forefront of not just polio vaccinations, but also the COVID too. And the reason being is because the reason they have found out in Pakistan and Afghanistan for the polio workers to deliver that message is because they have been into the communities time and time again. And they have traced and planned the immunization schedules of polio from birth. The families trust those workers, and they're essential to the polio eradication efforts. And as being on NIDs, as Sean said, those are the true heroes. The healthcare workers are the true heroes because they're out there every day. They're out there all the time, and they know exactly where those polio cases are. They know exactly where the children are that need to be immunized. I think Clay alluded to this and said this, and if you've heard me speak before, you always hear me say that the one thing is that polio is just a plane ride away. And we certainly realize that COVID certainly showed us how fast and how far viruses can travel. As you can see, you know, we still have many challenges, and we remain the same with some new challenges. People are getting fatigued. We're tired of giving. We're tired of hearing about polio, and we're tired of making sure that the polio vaccine is out there. I mean, I'm tired of it too. But until every child is vaccinated, every child in the world is vaccinated, the risk is still there. And I think if we can't see the similarities between COVID and polio, then I don't know what else to tell you. We must now ensure that the work that we have started and that we will continue, we need to protect those vulnerable children with the vaccine while ensuring strict safety hygiene measures to prevent any spread of polio and COVID. And I'm sure that when the polio vaccine comes out, especially in these developing countries, as Clay told you, I'm sure the polio workers will be on the forefront too of giving the vaccine to those people in danger. They're the ones that go out into the communities. A lot of times, especially in countries that are developing, you have to go to them. They don't come to the clinics. They're not able to travel. They're not educated enough to hear about what's happening. So we have to go to them. And that's why we go out into the field. The doctor from Africa that is, I think the head of WHO in Africa says, we cannot wait for the COVID-19 pandemic to be contained to resume all activities. If we stop immunization for too long, including for polio, vaccine preventable diseases will have a detrimental effect on children's health. Now, I think we've seen that. We've seen that with COVID. And thank goodness that now a vaccine has been developed and is coming. That does give us hope, and it does give us a reason to celebrate. It amazes me that, that the polio workers not only deliver vaccine, but there are research labs and there are surveillance going on in the endemic countries and places where polio has been affected. They have detected defection. And it is amazing that they can detect exactly where the polio virus is. They trace it. They take samples in sewer systems and all kinds of places, and they can pinpoint exactly where where that virus has started. I'm sure that they have done the same thing with COVID. I don't know for sure, but I'm pretty sure that they can do the same thing. We do have an oral vaccine, and it's called OPV, and those are the ones, if you go on an NID, that are delivered, that we can deliver. I certainly wouldn't want to be one of those to give a shot, I can tell you. It's hard enough to open up a baby wiggling's mouth to get the polio vaccine in, and can't imagine giving them a shot. But that is a live virus that is given, and there are derived cases from the live virus. It is very rare. I think Clay talked about this too with COVID, that yes, some people do have ill effects from a live virus, and but it's rare. It's very rare. And that doesn't mean that just because 1 or 2 people have had that, or even 10 people, the rest of the population, the millions that receive it, can be saved from a dreadful disease like COVID and also like polio. There is no cure for polio, but it is preventable. And that's what's so sad when we talk about people that don't believe in vaccinations, because they would hate for their child to be the one that was affected and have paralysis. I mean, it's horrible. It's a horrible life to live because it doesn't go away. And we've learned in the recent years that people with polio, they may have a time when it lies dormant and they don't have many effects, but later on in life it can come back, and it can come back with a vengeance, and they are affected greatly, and sometimes even to the point of death. So we want to make sure that the polio vaccine is continued. We want to make sure that we continue to raise funds for that. You know, as you well know, we have a match from Bill and Melinda Gates. And while that is going on, and I think he'll continue that until polio is completely eradicated. And someone told me the other day, I was glad to hear it, that he was on CNN and gave Rotary a lot of credit for eradication of polio, because without Rotary involved in polio eradication, I don't believe it would be this close to being complete. And we must continue to do that. I just have to say thank you so much for all that you do for polio. I know your district, I know your clubs do a lot for polio. You had a big polio event recently, and you raised a lot of money for polio. And I just want to say thank you so much, because it is important. And when polio is completely eradicated, you can say, I was there. Didn't matter. It does not matter if you drop those 2 precious drops. Does not matter how big an effort you made. If you made one tiny step, that means you were part of it too. And I just have to say thank you so much for the legacy that Rotary will leave for the eradication of polio. Thank you, Sean.
Well, Nancy, thank you for the kind words for our district and the people in it, but it's part of the value that we have realized in those efforts is the one that you share and provide to us on a regular basis. So I thank you for not only just being you, I thank you for being here, and I thank you for the value that you've brought to the conversation tonight. In fact, I thank everybody that spoke and presented, from Clay Marsh to Mary Berg and to Nancy. Again, I'm thrilled to see that this many people had taken the time out of their busy schedules and just general craziness that our world is right now to be able to sit and share, and we're well represented, and you all are fantastic people. I want to apologize. You knew when I said I was going to try to keep us on time that I was not going to be able to do that. For those of you who don't know, probably Clay's the only one that doesn't know that. I'm famous for that, saying, oh yeah, we're going to keep this within an hour. And then 3 days later, everybody's looking at their watch and saying, why in the heck is this guy still talking? So, I've as your governor, I've never been the governor without Corona. I wouldn't know what it would be like to be the governor without Corona. I'm sure they're not going to let me be the governor again to find out what it's going to be like to be governor without Corona. But if someone needed to be the trying to lead us all through this time on behalf of this district, I'm glad that it's me, and it wouldn't be possible without the support and input from every single person that's on this call. I know every one of you, and I thank all of you for who you are and for being here as well. So if we have no further questions, I know there's other places and things that you'd like to tend to. Again, I appreciate all of you for being here, particularly our speakers for sharing with us. If there's ever anything I can do to repay the favor to any of you, please, I'm very easy to find. Let me know. Otherwise, if there's no more questions, I wish all of you to stay safe and healthy, and let's all hold Clay true to his promises that we're all going to be in a COVID-free environment here and not the too distant future, right? Okay. Well, thank you all for being part of this. I'm glad you're able to participate. I'll see you all soon. Take care of yourselves.